Good morning, everyone. I'll be presenting on my paper is the treatment of non-infectious pediatric uveitis grueling for an ophthalmologist. So at our clinic, 7% of our uveitis patients fall in the pediatric age group, with complications occurring in 30 to 60% and legal blindness in 7 to 23%. The reason why this is so high is children are often asymptomatic because they are unable to express their symptoms. In addition, the difficult ocular examination, treatment non-compliance, and the need for long-term follow-up make treatment a difficult task. Amblyopia further contributes to a poor visual prognosis. So the aim of our study was to determine treatment outcomes of non-infectious pediatric uveitis in the era of immunosuppressants and newer biologicals. We analyzed retrospectively clinical records of our patients from February 2023 to April 2023. We followed a step-ladder approach in treatment of all our patients. First, we would start with topical and systemic corticosteroids. If it was not sufficient, we would switch to immunosuppressants, the first being methotrexate, the second option being MMF. If they were not effective, we would switch on to adalimumab. And if adalimumab was still not effective, our last defense was cyclophosphamide. We studied a total of 27 pediatric patients, and for comparison, we studied 27 adult patients as well. The pediatric patients, majority were female, and the most common uveitis was a bilateral non-granulomatous uveitis, falling mainly in the intermediate anatomical classification, followed by then anterior and panuveitis. The most common etiology was sarcoidosis and idiopathic cause. When they presented to us, we found that pediatric patients were mostly visually impaired with a vision less than 6/18 in 41%, while in adults it was only 22%. In the pediatric age group, the most common complications at presentation were band-shaped keratopathy, complicated cataract, and posterior synechiae. While in adults, we had only one patient with band-shaped keratopathy, and it was not involving visual axis. We found that in adults, most of them responded with the first immunosuppressant used, while in pediatric patients, we had to switch on to a second immunosuppressant. Overall, when we started immunosuppressants, the mean time from presentation to starting was 7.34 months. If we switched on to the second immunosuppressant, it was 19.38 months. And if we used a new biological, it was at 19.5 months. We started immunosuppressant cases. So in our study, 4 children needed to be stepped up to adalimumab, and in 2 of these patients only inflammation was well controlled. In the other, we had to switch to cyclophosphamide, and in another patient, they still had active uveitis. So our study highlights that we can reduce corticosteroids, thus avoiding the long-term side effects in children. The poor visual outcome was due to cataract, cystoid macular edema, and band-shaped keratopathy. IOL implants also went into subluxation optic capture in children more than adults. So basically what our study wants to point out is that we need to be more aggressive in treatment of pediatric uveitis. And with the help of more drugs being studied, such as rituximab, golimumab, and JAK inhibitors in pediatric uveitis, hopefully we'll be able to achieve better and longer duration of control. Thank you.
So, how many of your patients have achieved complete remission? Because you have told that there are patients who are having still some activity. So, I think that the total purpose of giving those immunomodulators or biologics has not been satisfied.
Yes, sir. Because we felt that we were starting immunomodulators a bit late, like 6 months, maybe too late. Maybe we need to start earlier, especially in children. We should not wait too long and be afraid to start immunomodulators.
And when you have decided to start that biologics or immunomodulators?
Yes, sir. In our study, we were starting at around after at least 20 months, almost a year after presenting to us. So we feel that we should start earlier on biologics.
And in your that treatment algorithm, you have mentioned that you have started kids on either prednisolone acetate eye drop or difluprednate eye drop. So what I think that difluprednate is very much notorious to raise IOP, particularly in kids, and it has been seen that about 30% of kids they have a very high chance of getting high IOP. But in your that complication aspect of those pediatric uveitis patient, I haven't seen even in a single case of raised IOP.
Yes, sir. We were monitoring the IOP, sir, at all cases. So our patients had not developed raised IOP. At every visit, we were monitoring, sir.
And how many patients were there? The etiology wise, how many patients were there of HLA-B27 or GIA associated uveitis?
So in HLA-B27 was mostly seen in the adults, sir. So that was around 30%.
GIA patients, I am very much particular about GIA patients.
GI patients were around 30%. We have found more number of patients having pars planitis compared to GIA, sir, in our study.
No, GIA is associated with HLA-B27,
Yes,
and
sir.
I think that should be ruled out because GIA is very much notorious.
Yes, sir. Yes, sir.
And one more thing I have noticed that what age you have taken for that pediatric subset?
The youngest was 7 years, sir. From 7 years up to
No, the
18.
cutoff value.
Less than 18.
I
was
think
the
it is
cutoff.
16.
Okay,
If we talk about pediatric uveitis, it is less than 16 years.
Okay, sir. Okay. Yeah, we took up to 18. Yes, sir.
Oh, actually, it is. If you will go with that the book that uveitis that written by Stephen Foster, you will see that the pediatric uveitis they describe it as below 16 years.
Yes, yes, sir. That is true. That is
Okay, thank you.
Yes, sir. Thank you.
One question. After this study, has it changed the practice pattern in pediatric uveitis? Now, are you starting immunosuppression in the first instance along with the steroids, than waiting for the steroids to not respond and then start immunosuppression? Like in Behçet's and VKH, we do that for adults. In
Yeah.
pediatric, has it changed the?
Yes, sir. In pediatric, at our first visit, we'll always start with oral steroids only, sir, and see the response. Then by their second or third visit, if we see that there's still active inflammation, we will start, sir. We will
But
not wait.
Not at the outset. You will not start with the immunosuppression because we know that a lot of patients will not be able to control with only steroids.
Yes, sir, but still not at the outset, sir, because because immunosuppressants still have their own side effects, sir. So we just want to see that if they are responding to oral steroids or not.